Hello everyone, I hope you're all doing okay. This lecture is on the conduction system of the heart. So as part of this lecture, we will talk about the anatomy of the conduction system of the heart. We will also see how the autonomic nervous system modulates the heart rate. So how does the sympathetic nervous system increases the heart rate and how does the parasympathetic nervous system decreases the heart rate. Now, what you're looking over here is a section or a slice which has been taken through the heart in such a way that you can see all the four chambers of the heart at the same time. So you can see the right and the right atrium here. This is the right ventricle. You can see the atrioventricular valve through which the blood is going to flow and enter from the atrium into the ventricle. Then on the left side, you can see the left atrium and the left ventricle. You can see the openings of the four pulmonary veins over here as well, telling you that you are looking at the left atrial chamber over here. And then we can see the big vessels coming into the heart or coming out of the heart very nicely. Now, here you can see that the conduction system is shown color coded in yellow over here. This conduction system of the heart generates and transmits electrical impulses which cause coordinated contraction of the cardiac muscle, which is shown in red over here, thus allowing the heart to contract in a cyclical fashion during systole and during diastole. This conduction system is formed of conducting fibers and nodal tissues, and we'll talk about the AV node and the SA node in a second. Now, the conduction system of the heart comprises of five distinct components. These include the SA node or the sinoatrial node, the atrioventricular node, and then there are internodal fibers which are connecting the SA node with the AV node. Then we've got the atrioventricular bundle of His. This bundle then splits up into right and left bundle branches, which descend along either side of the interventricular septum. And finally, the right and left bundle branches split up into loads of Purkinje fibers, which spread across the muscle wall and eventually cause the heart muscle to contract. Now, once again, you're looking at that same slice of the heart where you can see all the four chambers of the heart simultaneously. This is the right side of the heart with the right atrium and the right ventricle, and this is the left side with the left atrium and the left ventricle clearly shown over here, all four chambers at the same time. Now, the entire muscular wall of the heart is going to contract as a result of electrical impulses which are being sent by a particular part of the conduction system of the heart, which is known as the SA node or the sinoatrial node, also known as the sinus node. The question is, where is the SA node situated? Well, it is actually a group of cells which are located inside the wall of the myocardium, inside the wall of the right atrium, at the junction of the superior vena cava with the right atrium. And this is the point where the crista terminalis ends as well. Crista terminalis is nothing but a muscular groove which is present within the right atrium, and it extends from the entrance of the superior vena cava all the way down to the entrance of the inferior vena cava, and kind of separates the rough part of the heart from the smooth part. The rough part would be containing loads of pectinate muscles, and the smooth part is the area where the blood vessels such as the SVC and the IVC, they open up into the right atrium. Now, the main role of the SA node or the sinoatrial nodal cell is to initiate action potentials of the heart that can pass through the cardiac muscle cells and cause contraction, thus producing a heartbeat. An action potential is a rapid change in membrane potential produced by the movement of ions in the absence of stimulation. The non-pacemaker cells, such as the muscular cells of the ventricle and the atria, they have a relatively constant membrane potential. This is known as the resting membrane potential. This resting potential ends when an action potential reaches those cells. This produces a positive change in membrane potential, which is known as depolarization, which is propagated throughout the heart, initiating a contraction of the cardiac muscle. Now, since the SA nodal cells, they serve as the pacemaker cells of the heart, they do not have a resting membrane potential. Instead, immediately after repolarization, the membrane potentials of these cells begins to depolarize again automatically, a phenomenon which is known as the pacemaker potential. Once the pacemaker potential reaches a set value, which is known as the threshold potential. So once that threshold potential is crossed, it automatically produces an action potential. Other cells within the heart, including the atrioventricular node and the Purkinje fiber cells, they can also initiate action potentials. However, they do so at a slower rate, and therefore the area of the myocardium that depolarizes the fastest that captures the rest of the myocardium. And that is why if the SA node is functioning properly, then its action potentials they usually override those that would be produced by other parts of the conduction system, and hence SA node serves as the main pacemaker of the heart. Now, as far as the blood supply of the SA node is concerned, the SA node receives its blood supply from the sinoatrial nodal artery, which is shown in this angiogram over here as well. The SA nodal artery mainly originates as a branch of the right coronary artery. However, in some individuals, it may also arise from the circumflex artery, which is a branch of the left coronary artery. But the dominant blood supply for the SA node in most of the cases is from the right coronary artery. Now here you're looking at a low magnification stained image of the SA node and its surrounding tissue. The SA node is situated in the center right of the image over here that surrounds the sinoatrial nodal artery or the SA nodal artery, which is a branch of the right coronary artery, and you can see the lumen of that artery very clearly over here. Cardiac muscle cells of the right atrium can be seen on the left, so you can see the cardiac muscle fibers over here, and the fat tissue can be seen over here on to the right side. Immediately surrounding the SA node are the paranodal cells. The connective tissue, along with the paranodal cells, they insulate the sinoatrial node from the rest of the atrium, preventing the electrical activity of the atrial cells from affecting the SA nodal cells. The SA-nodal cells are much paler, smaller than the surrounding atrial cells. Unlike the atrial cells, the SA-nodal cells also contain fewer mitochondria, fewer myofibers, and much smaller sarcoplasmic reticulum. This means that the SA-nodal cells are less equipped to contract compared to the surrounding atrial and ventricular muscle cells. Action potentials they pass from one cardiac cell to the next through pores, which are known as the gap junctions. And there are fewer gap junctions within the SA node, and they're much smaller in size as well. And this once again is an important factor in insulating the SA node from the surrounding atrial cells. So now we know that the electrical impulses are generated inside the SA node. The conduction of depolarization waves from the sinoatrial node across the right atrium to the atrioventricular node occurs through three internodal tracts. These are the anterior, the middle, and the posterior internodal tract. The anterior tract, in addition, also gives rise to a trapezoid-shaped bundle of fibers which course along the superior quadrant of the interatrial sulcus from the right atrium into the left atrium. This bundle is called as the Bachmann's bundle, and the conduction of electrical impulses from the right atrium to the left atrium occurs through this tract. During sinus rhythm, the electrical impulses originate inside the right atrium and they move to the left atrium predominantly across this Bachmann's bundle, thus enabling almost simultaneous depolarization of both the right as well as the left atria, thus maintaining synchrony. The right coronary artery, which supplies the SA node, that also supplies the Bachmann's bundle popping off from the SA node going into the left atrium. Now, the heart receives its autonomic innervation via plexus of nerves, which is called the cardiac plexus. In the figure over here, see the sternum has been removed and the heart has been removed as well. You can see the arch of the aorta continuing down as a descending aorta, while the ascending part of the aorta has been removed so that you can see the trachea and its bifurcation very clearly. The cardiac plexus is situated over here between the trachea at the back and the ascending part of the aorta in the front. This is a plexus of nerves which receives autonomic motor fibers, including the parasympathetic and sympathetic efferent fibers, which are coming to the heart, and also contains the visceral afferent or the sensory fibers, which are coming from the heart, bringing information into the central nervous system, such as the spinal cord. These autonomic fibers, in addition to the cardiac muscle, also supply innervation to the coronary vessels and to the conducting system of the heart. Now, the rate at which the SA node generates impulses is influenced by the autonomic nervous system. The sympathetic nervous system increases the firing of the SA node and thus increases the heart rate, while the parasympathetic nervous system decreases the firing rate of the SA node and thus decreases the heart rate. The sympathetic innervation comes from the T1 to T6 segments of the spinal cord. For instance, if you look over here, you can see this is a cut section, a horizontal slice which has been taken through the spinal cord. And what you can see over here is that the sympathetic innervation comprises of a preganglionic and a postganglionic autonomic neuron. The preganglionic neuron pops out from the lateral horn of the spinal cord in the T1 to T6 segments of the spinal cord. These preganglionic autonomic motor neurons, which are sympathetic autonomic motor neurons, they're going to be traveling through the anterior roots of the spinal nerve to reach the spinal nerve and then eventually enter into the anterior rami of the spinal nerve. The posterior ramus hasn't been shown in this illustration here. Now, these preganglionic neurons from the anterior rami are then going to enter into the sympathetic trunk through the communicants. Inside the sympathetic trunk, these preganglionic neurons are going to synapse with the cell bodies of the postganglionic neurons in the cervical and superior thoracic sympathetic ganglia. The postganglionic sympathetic neurons then travel through the anterior rami to innervate the cardiac tissue. The parasympathetic innervation comes from the vagus nerve. So, for instance, over here you can see a horizontal slice which has been taken through the medulla oblongata, which is the lower part of the brainstem. Here you can see a cut section of a nucleus, which is called the dorsal motor nucleus of vagus. That is the nucleus which gives off general visceral efferent fibers, which are the vagal nerve fibers. These fibers run through the vagus nerves. These are the parasympathetic preganglionic neurons, and you can see the preganglionic parasympathetic neurons are fairly long neurons compared to the sympathetic preganglionic neurons. These neurons are going to reach near the cardiac tissue where they will synapse with the cell bodies of the postganglionic parasympathetic neurons, which then innervate the cardiac pacemaker tissue, such as the SA node and to the AV node as well. The atrioventricular node or the AV node is that part of the electrical conduction system of the heart which connects the atria with the ventricles. It lies at the lower back section of the interatrial septum near the opening of the coronary sinus and conducts the normal electrical impulses from the atria into the ventricles. The blood supply of the AV node is coming from the atrioventricular nodal branch of the right coronary artery, which in some cases also originates from the left circumflex artery, that is a branch of the left coronary artery. This is associated with the dominance of the coronary artery circulation, meaning thereby that in a right dominant individual, the blood supply is coming from the right coronary artery, whereas in a left dominant individual, the AV node receives its blood supply from the left circumflex artery. Now, a wave of excitation spreads out from the sinoatrial or the SA node through the atria along specialized conduction channels. This activates the AV node. The AV node then distributes the signals to the ventricles via the AV bundle or the AV bundle of His. The atrioventricular node delays the impulses by approximately 0.09 seconds or by approximately 1 second. This delay in the cardiac impulse is extremely important. It ensures that the atria have ejected their blood into the ventricles first before the ventricles contract. This also protects the ventricles from excessively fast rate response to atrial arrhythmias, for instance. The normal intrinsic rate of depolarization of the AV node is close to 50 beats per minute, which is slower than the SA node. If the SA node fails to function, for example, because of poor blood supply, the area with the next fastest intrinsic rate of depolarization, that is the AV node, that'll take over, driving the heart's contractions at approximately 50 beats per minute now. At the junction of the membranous and the muscular part of the interventricular septum, the AV bundle then divides into bundle branches to continue down along the interventricular septum. There are two branches of the bundle of His, the left bundle branch and the right bundle branch, both of which are located along the interventricular septum, one on either side of the septum. The left bundle branch divides further into left anterior fascicles and the left posterior fascicles. These structures then lead to a network of thin filaments known as the Purkinje fibers. The fascicles play an integral role in the electrical conduction system of the heart by transmitting cardiac action potentials to the Purkinje fibers. The Purkinje fibers then spread out to cause the contraction of the cardiac muscle. Now here what you can see is a horizontal cut section which has been taken through the heart. You can see the right ventricle over here, and this is the concentric left ventricular cavity. Overall the musculature is much more bigger on the left side as well. So this is the left side of the heart, that's the right side. What you can see is a pathological specimen of the heart which has undergone infarction of the septum shown over here. This has disrupted the conduction system of the heart. In a complete heart block, when the conduction of electrical impulses to the ventricles is interrupted, then the ventricles will beat at the depolarization rate of the next component of the conduction system, which in this case would be the Purkinje fibers. Their intrinsic depolarization rate is close to 30 to 40 beats per minute. The right and left bundle branches, they then divide into Purkinje fibers, which extend into the walls of their respective ventricles, just underneath the endocardium in a space called the subendocardial space. The Purkinje fibers on the right side, they stimulate the muscles of the interventricular septum and the wall of the right ventricle, including the anterior papillary muscle through a connection between the septum and the anterior papillary muscle, which is known as the moderator band. The Purkinje fibers on the left side, they stimulate the interventricular septum and the wall of the left ventricle, including the papillary muscles. In the UK, the pacemaker implantation is one of the most common types of heart surgeries carried out, with many thousands of pacemakers fitted each year. If you need to have a pacemaker fitted, then it can be surgically implanted into the chest. The pacemaker then sends electrical impulses to the heart to keep it beating regularly and not too slowly. Having a pacemaker can significantly improve one's quality of life if he or she has problems with a slower heart rate. The device can be potentially life-saving. You might be wondering that how does a pacemaker work? Well, it is about the size of a matchbox or smaller and weighs about 20 to 50 grams in weight. It consists of a pulse generator, which is shown over here, that emits electrical impulses through the wires to the heart. The wires have been shown over here. The rate at which the electrical impulses are sent out, this is known as the pacing rate. Almost all modern pacemakers, they work on demand. This means that they can be programmed to adjust the discharge rate in response to one's body's needs. If the pacemaker senses that the heart has missed a beat or is beating too slowly, then it sends out signals at a steady rate. If it senses that the heart is beating normally by itself, then it does not send out any signals. Most of the pacemakers, they have a special sensor which also recognizes the body movements or the breathing rate. This allows them to speed up the discharge rate when one is active. Doctors describe this as the rate responsive pacemakers. Having a pacemaker implanted is a relatively straightforward process. It usually is carried out under local anesthesia, which means that the person will be awake during the procedure. The pulse generator is usually placed under the skin near the collarbone in the pectoral region on the left side of the chest, although the axilla is sometimes used in children or sometimes abdomen for other systems of pacemakers. The pocket can be either subcutaneous at the level of the prepectoral fascia, or for lean people with less adipose tissue, the pulse generator is placed in a submuscular plane to prevent erosion. The submuscular plane is usually below the pectoralis major. It could be between the pectoralis major and minor, or even between the pectoralis minor and the rib cage. The generator is usually attached to a wire, and that wire is guided through a blood vessel into the heart. A common route, for instance, could be accessing the subclavian vein and then guiding the wire through the brachiocephalic vein and then the superior vena cava to enter into the right atrium of the heart. The procedure usually takes about an hour, and most people are able to leave the hospital on the same day or the day after the surgery. This is a schematic to show the transvenous implantation of the pacemaker. During the transvenous implantation, the cardiologist will make a 5 to 6 centimeter long cut just below the collarbone, just below the clavicle, usually on the left side of the chest, and then inserts the wires of the pacemaker, which are the pacing leads, into the vein, in this case into the subclavian vein. The pacing leads are guided along the vein into the correct chamber of the heart using X-ray scans. These then become lodged into the tissue of your heart. The other ends of the leads are then connected to the pacemaker, which, as I mentioned before as well, is fitted into a small pocket created by the cardiologist between the skin of the patient's upper chest and his chest muscle. The transvenous implantation is carried out under local anesthesia, which is given as an injection. This means that the area where the cuts are made is obviously numbed, but the patient remains awake during the procedure.